Hi everybody, and welcome to our module on the brainstem. Before we talk about the brainstem, let me define a little terminology because it can be confusing, especially when textbooks use formal language to describe the brainstem. So when we say something is dorsal, we mean it's posterior and towards the back. You may know that fish have a dorsal fin and that's on their back. When we say something is ventral, we mean it's anterior or towards the front. When we say something is rostral, that means towards the top of the head. And then when we say something is caudal, we mean it's towards the tail or away from the head. So the brainstem is at the base of the brain just above the spinal cord, and there are three components to the brainstem: the medulla, the pons, and the midbrain. And you can see it over here in this MRI image of the head. This is the medulla here. You can see the pons, which has a little bulging outgrowth, and then the midbrain is just above it right up here. So what's inside the brainstem? Well, there are sensory and motor fibers, there are nuclei for the cranial nerves, and the most important things for you to know are what lies in each section. You're going to be asked on your board exams about different things, and are they found in the midbrain or the pons or the medulla, so you should certainly know that. Know which cranial nerves are at each level, know what tracks are traveling between the brain and the spinal cord. We'll talk more about that. And then very important to focus on what structures are medial or lateral. The stroke syndromes for the brainstem are often defined as a medial medullary syndrome, for example, or a lateral pontine. So in order to understand which syndrome you're looking at, you need to know which structures are medial and lateral. So one of the most basic skills you need to have regarding the brainstem is to be able to identify which section you are looking at based on a drawing. So on this picture here, I've drawn the midbrain up here, the pons over here on the right, and then down at the left is the medulla. So how can you tell which section you are looking at? Well, the medulla and the pons both have the fourth ventricle up at the top portion of the picture. I'm drawing where the fourth ventricle is on both of these right now. The midbrain, on the other hand, does not have the fourth ventricle. Instead, you see this little circle, which is the cerebral aqueduct. So when you don't see the fourth ventricle, you are usually looking at the midbrain. You can also recognize the midbrain by the very characteristic view of the third cranial nerve that you have right here. It almost looks like a spider's leg sticking out. So when you see those spider's legs and you see the circle and no fourth ventricle, you know you're looking at the midbrain, like up here. The best way to tell the difference between the pons and the medulla is to look for the inferior olivary nucleus, which I'm circling right here. It's got a very striking shape that's easy to recognize, and when you see that, you know you're looking at the medulla. The inferior olivary nucleus is associated with the cerebellum. We actually don't understand very well what it does, but people have used it for a long time to know they're looking at the medulla. The pons, on the other hand, has the fourth ventricle and no inferior olivary nucleus. So what I'm going to do now is go through each level of the brainstem and point out the key structures that cause most of the symptoms in clinical syndromes. You're going to see far fewer things labeled in these drawings than you'll find in some textbooks, and that's because I'm only labeling the things that cause most of the symptoms patients will have in questions you're presented with. They'll show you a patient who has various neurologic symptoms and ask you where the lesion is in the brainstem. The tracts and nerves I'm labeling will help you answer those questions. So let's start with the midbrain first. So here's the spinal thalamic tract right here. I'm drawing it with these lines right now, and that's carrying pain and temperature information. Here's the medial lemniscus right here. So this is connected to the posterior columns in the spinal cord, and it's carrying proprioception and vibration information. There's a structure here called the red nucleus, which is this big round structure right here, and that's actually important for fine-tuning of movements. If it gets a lesion in the midbrain, what you get is tremor and ataxias because you can't fine-tune your movements. The ocular motor nerve is right here. It's this big spider leg looking thing coming down the middle. Over here on the bottom right is the cerebral peduncle. So the cerebral peduncle carries motor fibers. So you've got the corticospinal and corticobulbar tracts here. Damage to this area will cause upper motor neuron paralysis of the face and lower extremities. Right over here is the medial longitudinal fasciculus. It's this very small structure right here. So damage to that area will give you problems with lateral gaze. You will have something called an internuclear ophthalmoplegia, and I talk more about this condition in the module on neurological eye disorders. And then finally, I've shown you the cerebral aqueduct here just to help you orient you. That's the cerebrospinal fluid running through there going down to the fourth ventricle. So there are a couple of midbrain stroke syndromes that you should know, and the first one is called Benedict syndrome. So in this syndrome, you have damage to the area I've highlighted over here in this drawing, and basically you lose cranial nerve 3, the medial lemniscus, and the red nucleus. So the loss of cranial nerve 3 gives you an ocular motor palsy, which means the eye will be down and out, and the pupil will be dilated. Loss of the medial lemniscus gives you contralateral loss of proprioception and vibration. And then remember I said the red nucleus is involved in fine-tuning of movement, so damage to the red nucleus gives you tremor and ataxia. Next midbrain stroke syndrome is Weber syndrome. So you get damage to the area I've highlighted over here in this picture, and you lose cranial nerve 3, the corticospinal tract, and the corticobulbar tract. So once again, damage to cranial nerve 3 gives you an oculomotor nerve palsy. Loss of the corticospinal tract gives you contralateral hemiparesis, and the patient will have upper motor neuron signs on physical exam. And then loss of the corticobulbar tract gives you what's called a pseudobulbar palsy. This is upper motor neuron cranial nerve motor weakness. So these patients have an exaggerated gag reflex. They have a spastic tongue, and they have this speech called spastic dysarthria, which you can go watch someone with this on YouTube if you want. It's very harsh speech where it's hard to get the words out. And so the final midbrain stroke syndrome is called Paranode syndrome, and I've drawn a picture up here on the right of where the lesion is. This is a problem in the posterior midbrain, and there are some very peculiar structures back here. One of them is called the superior colliculus, another is called the pretectal area, and all you need to know about these areas is that they coordinate upward gaze. So when you look up and both your eyes move up together at the same time, it's coordinated by this area. So when you have damage, you get a vertical gaze palsy. Vertical gaze palsies are very rare, much more rare than horizontal gaze palsies, and pretty much the only thing you're likely to see that will cause this is a Paranode syndrome in the posterior midbrain. The patient will be unable to look up. Another peculiar sign of this syndrome is something called a pseudo-Argyll-Robinson pupil. So an Argyll-Robinson pupil is a pupil that does not constrict when you shine light in it, but it does constrict when you test accommodation by asking the patient to follow your finger into their nose. This is normally associated with tertiary syphilis, but the one exception is that you can also see it in a Paranode syndrome. This syndrome is very rare, but when it does happen, it happens because of rare tumors like a pinealoma or a germinoma in the pineal region. They can compress the posterior midbrain and cause this syndrome. Those lesions can also compress the cerebral aqueduct, which if you look up here on the right is this little circle in the middle of the screen. If that gets obstructed, you will get non-communicating hydrocephalus. So a pineal tumor can cause Paranode syndrome and can cause hydrocephalus. Next, we're going to talk about the pons, and once again I'm going to point out the key structures that cause most of the symptoms in patients who have pontine lesions. So we'll start right here with the vestibular nucleus, that's cranial nerve 8. So a lesion there will give patients vestibular dysfunction like nausea, vomiting, vertigo, and nystagmus. Right here we have cranial nerve 7, the facial nerve. It has a very unusual trajectory. It wraps around cranial nerve 6 and then leaves over here on the lateral side. So lesions to the facial nerve will give you facial droop and also loss of your corneal reflex. Right here is the medial lemniscus, just like we saw in the midbrain. That's connected to the posterior column of the spinal cord. So damage here gives you loss of proprioception and vibration. The cortical spinal tract is here running in against the midline, so damage there gives you hemiparesis. Here we've got the abducens nerve, cranial nerve 6. So damage here gives you problems with gaze, and I talk more about this in the module on neuro-eye disorders, but you need that to move your eyeball laterally. Moving on over here, we've got the spinothalamic tract, so damage here gives you loss of pain and temperature sensation. And then up here we have an important structure, the spinal tract and nucleus of the trigeminal nerve, cranial nerve 5. So that is what gives you pain and temperature sensation in your face. So damage there gives you facial loss of sensation. Up here at the top is the fourth ventricle, and then two structures I want to point out here are the medial longitudinal fasciculus, which I also pointed out in the midbrain, so problems there give you intranuclear ophthalmoplegia. And then also here is the paramedian pontine reticular formation, which is a key structure for lateral gaze. So if you want to be able to look left or right, you need three structures that are here. Right here is the abducens nucleus, right here is the PPRF, and right here is the medial longitudinal fasciculus. They're all close to each other in the pons, and damage there gives you lesions of gaze palsy. So the pontine stroke syndromes are a little bit different depending on whether you're inferior or superior, and textbooks will show you lots of different syndromes. What I'm going to do is just give you the general features of medial pontine and lateral pontine syndromes. So if you have a medial pontine syndrome, you'll get damage in the area I've highlighted down here in this drawing, and basically you will lose your cortical spinal tract, cranial nerve 6, and cranial nerve 7. So loss of the cortical spinal tract will give contralateral hemiparesis. Loss of cranial nerve 6 will give a cranial nerve 6 gaze palsy, and then loss of cranial nerve 7 will give you facial weakness and droop on the affected side. Also remember that the medial longitudinal fasciculus and the cranial nerve 6 nucleus and the paramedian pontine reticular formation are all midline structures that you need for lateral gaze. So you can get gaze palsies where you can't look to the affected side if you have damage to either the PPRF or the nucleus of cranial nerve 6. In a lateral pontine syndrome, you get damage to the area I've highlighted down here. So you will lose your vestibular nuclei, and patients will have nystagmus, vertigo, nausea, and vomiting. They will lose the spinothalamic tract, so they will get contralateral loss of pain and temperature in the arms and legs. They lose the spinal nucleus of cranial nerve 5, so they will have ipsilateral facial pain and temperature loss. Also, the sympathetic tract from the hypothalamus is running in the lateral pons, so you can get a Horner syndrome on that side. The facial nucleus and nerve can be affected here as well, giving you facial droop and loss of the corneal reflex. The cochlear nuclei are over here, so patients who have lateral pontine lesions can get hearing loss, and this can be caused classically by an anterior-inferior cerebellar artery stroke. So lastly, let's talk about the medulla. So right up here at the top is the nucleus solitarius and the dorsal motor nucleus of the vagus nerve. And this is where autonomic sensory information comes in from places like the carotid body and the aortic arch and then goes out to affect autonomic functions of the vagus nerve. Down here is the nucleus ambiguus, and this is a shared motor nucleus of 3 cranial nerves, 9, 10, and 11. So it sends fibers out that form the vagus nerve, cranial nerve 10. Down here we have cranial nerve 12, the hypoglossal nerve, and then right here in the middle we have the medial lemniscus. So remember, this is carrying proprioception and vibration information from the spinal cord. Down here is the cortical spinal tract, and it runs in these 2 bulges called the pyramids of the medulla, and that's why loss of corticospinal tract function is often referred to as pyramidal dysfunction. Here we have the inferior olivary nucleus, and remember I told you that doesn't do anything clinically important, but it's how you can recognize the medulla very easily. Here's the spinothalamic tract carrying pain and temperature information from the arms and legs. Up here we've got the nucleus and tract of the trigeminal nerve, so that's pain and temperature from that side of your face. This little circle right here is the hypothalamal spinal tract, so this is carrying your sympathetic nerve fibers from the thalamus, and damage there will give you a Horner syndrome. And then up here we have some more vestibular nuclei. They're very large and they run up and down through the pons and the medulla. So a medial medullary syndrome affects the structures I've shown down here in this picture on the right, and you lose the corticospinal tracts running in the pyramids, the medial lemniscus, and cranial nerve 12. So patients get contralateral hemiparesis and contralateral loss of proprioception and vibration, and then they have flaccid paralysis of the tongue, and it deviates to the side of the lesion. And you can get this from a stroke in the anterospinal artery. The anterospinal artery runs right here and supplies this whole region. A lateral medullary syndrome is also called Wallenberg syndrome, and here you lose the vestibular nuclei, so you get nystagmus, vertigo, nausea, and vomiting. You also lose the sympathetic tract, so you can get a Horner syndrome. There's loss of the spinothalamic tract, so contralateral pain and temperature are gone. Spinal nucleus of cranial nerve 5 is lost, so you get ipsilateral facial pain and temperature. And then you also lose the nucleus ambiguus, so you get hoarseness and dysphagia. And the lateral medullary syndrome can look a lot like the lateral pontine syndrome, so this presence of hoarseness and dysphagia really helps, because that lets you know you're in the medulla and that you're losing the vagus nerve. And this can be caused by a pica stroke. So on your board exams, they are going to present you with patients who have a constellation of neurological findings and ask you where the lesion is. So one way to figure out where the lesion is to know all those syndromes I've just described, but that's very difficult. But the much easier way is to use something called the rule of fours. And I'm going to spend the rest of this module explaining to you how to use the rule of fours, because it makes these brainstem questions very simple. So the rule of fours was a paper written by a guy named Peter Gates in 2005, and if you have the time, I recommend you read the original paper. It's very interesting and it will really help with brainstem problems. And he created the rule of fours to essentially help medical students find brainstem lesions. So let's talk about what the rule of fours is. The rule of fours says that there are 4 cranial nerves in the medulla, 4 in the pons, and 4 above the pons. It also says that the 4 cranial nerves that divide evenly into 12 have midline motor nuclei. So 3 divides evenly into 12, so does 4, so does 6, so does 12, and all these are midline cranial nerves. The 4 cranial nerves that do not divide evenly into 12 are all lateral. So cranial nerve 5, 7, 9, 11, none of these numbers divide evenly into 12. So those are all lateral cranial nerves. He also says that there are 4 midline columns that all start with M. So the first one is the motor nucleus. We'll talk about that in a minute. The next is the motor pathway. That's the corticospinal tract. The medial longitudinal fasciculus is a midline structure, and the medial lemniscus is a midline structure. And all of these tracts and structures begin with the letter M to remind you that they're midline. Then the final part of the rule of fours is that the 4 lateral or side columns all begin with the letter S. So the sympathetic tracts are lateral columns. The spinothalamic tract is a lateral column. Sensory to the face, we'll talk about this in a minute, is a lateral column. And the spinocerebellar tract is a lateral column. And these all begin with S. So these are the rule of fours, and I'm going to explain to you how to use them in the next couple of slides. So basically the rule of fours helps you localize lesions by saying, is it medial or lateral? And you can determine that by which tracts are affected, and also to some degree which cranial nerves. And then you're going to tell whether it's medulla versus pons or midbrain by which cranial nerves are affected. Basically it's like an axis. I've drawn it down here. And the cranial nerve tells you how high to go up the axis from medulla to midbrain, and the tracts tell you whether to go lateral or midline. So in board questions, they're going to give you patient symptoms, and you need to be able to convert those symptoms into cranial nerves or tracts if you want to use the rule of fours. So let's talk about how to convert clues from the patient's symptoms into cranial nerves or tracts. So remember, there are 4 cranial nerves above the pons according to the rule of fours. Cranial nerves 1 and 2 we don't need to worry about because they're not in the midbrain or brainstem. So ocular motor nerve damage, cranial nerve 3, gives you an eye that's turned down and out. And when you see that, they're describing cranial nerve 3 involvement. The trochlear nerve, cranial nerve 4, gives you an eye that's unable to look down when looking towards the nose. And so if you see this, they are describing cranial nerve 4. The rule of fours also says there's 4 cranial nerves in the pons. So if you have trigeminal nerve involvement, you will have ipsilateral facial sensory loss. If you have abducens nerve involvement, you will have ipsilateral eye abduction weakness. So abduction is looking away from the nose, and you won't be able to do that with a cranial nerve 6 lesion. Facial nerve involvement will give you ipsilateral facial weakness and droop, and then cranial nerve 8 involvement will give you ipsilateral deafness. Finally, there are 4 cranial nerves in the medulla. So if you have damage to the glossal pharyngeal nerve, you will have ipsilateral pharyngeal sensory loss. If you have damage to the vagus nerve, you will have palatal weakness. If you have damage to cranial nerve 11, you will have shoulder weakness. And if you have damage to cranial nerve 12, you'll have weakness of the tongue. So that's how to convert clues from symptoms into cranial nerves. Now let's talk about how to convert clues from symptoms into midline structures. So if you have damage to the motor pathway, that's the first M for midline structures, that's corticospinal tract damage, and you have contralateral weakness. If you have damage to the medial lemniscus, you have loss of contralateral proprioception and vibration. If you have damage to the medial longitudinal fasciculus, you have an ipsilateral intranuclear ophthalmoplegia, and watch our module on neuro eye disorders to learn how to recognize this. And then finally, if you have damage to one of the motor nuclei of one of the cranial nerves that divide evenly into 12, which are 3, 4, 6, and 12, then it also identifies a midline stroke syndrome. The lateral structures or the side structures all begin with S, so if you have damage to the spinocerebellar pathway, you get ipsilateral ataxia. If you have damage to the spinothalamic tract, you have contralateral loss of temperature and pain sensory loss. If you have damage to the nucleus of cranial nerve 5, you get ipsilateral pain and temperature loss in the face. And then if you lose the sympathetic pathway, you have a Horner syndrome on that side. And all these structures begin with S to remind you that they are on the side or lateral. Let me mention a couple of caveats I've learned from applying the rule of fours to brainstem problems over time. The first involves the trigeminal nerve. A lesion of cranial nerve 5 gives you loss of ipsilateral pain and temperature sensation to the face. This applies to 2 points in the rule of fours. First of all, cranial nerve 5 localizes to the pons according to the rule of fours. It also localizes to the side. It's a lateral tract. My advice to you is don't use it to localize to the pons. This is a big cranial nerve and it stretches through the pons in the medulla. Use the loss of pain and temperature sensation to the face to localize as a lateral problem versus a medial problem. Second caveat involves cranial nerve 8, the vestibulocochlear. Don't use vestibular signs to localize to the pons. The vestibular nuclei are large and they stretch through both the medulla and the pons. So in the paper on the rule of fours, he specifically mentions that you should only use hearing loss to localize cranial nerve 8 to the pons, not the vestibular signs. So the easiest way to understand the rule of fours is to go through a couple of cases and use the tools. So let's do that right now. So case 1 is a 75-year-old man who presents for an evaluation of weakness. He reports that 2 hours ago he suddenly was unable to move his left arm or leg. He denies any difficulty with speech. On exam he is able to move all facial muscles normally. There is no ophthalmoplegia. On tongue protrusion the tongue is deviated to the right. He's unable to detect lower or upper extremity vibration on the left. So let me break down this case for you and find the lesion using the rule of fours and some of the other clues in the stem. So first of all, this man has complete motor weakness. So right away you know it's not an MCA or ACA stroke. Those cerebral stroke syndromes give you more arm than leg symptoms or more leg than arm symptoms. But here we have a lesion somewhere where all the motor fibers are running together. We also know that the tongue's involved, so it must be a brainstem lesion. So there is evidence of motor pathway involvement because his left side is weak. And remember, motor pathway begins with M, so this must be a medial lesion, and it must be on the right because his left side is weak. So we've already decided that we have a right medial lesion, which that in of itself may get you the question right on the boards. We also know that there is medial lemniscus involvement because he's lost vibration and proprioception on the left. So this also tells us it's a right medial lesion. And then finally, cranial nerve 12 is involved because the tongue is deviated, so it must be in the medulla. So the answer is that this is a right medial medullary syndrome, and the artery that causes that is the anterior spinal artery. If you have trouble remembering which blood vessels supply which part of the brainstem, you may find this picture very helpful. On the right side of the screen, I've drawn the midbrain, the pons, and the medulla, and I've drawn the cranial nerves that are found at each section. You'll notice that I've drawn 3, 4, 6, and 12 as midline cranial nerves because they divide evenly into number 12, and therefore, according to the rule of fours, those are midline cranial nerves. Over here on the left side of the screen, I've drawn the major blood vessels that supply each level. Now, there are more vessels than the ones I've drawn here, but these are the ones responsible for most of the clinically important stroke syndromes. So the PCA causes most of the stroke syndromes in the midbrain. In the pons, the basal artery gives a medial stroke syndrome, where the ICA gives a lateral stroke syndrome. In the medulla, the pica gives a lateral stroke syndrome, where the anterior spinal artery gives a medial stroke syndrome. So if you can just remember this picture, it can be very helpful during your boards. This is the kind of thing I recommend you write down as soon as you get into your exam. They give you some scratch paper, and if you can draw this, then you can just use it for reference during your test. So let's do another case, and for simplicity I'm not going to write out the whole stem, I'm just going to tell you the symptoms. So we have a patient with right-sided weakness, and the left eye is down, out, and dilated. So the right-sided weakness means there's motor pathway involvement, and so it must be a medial lesion. And again, it's complete motor loss, not MCA or ACA. The left eye is down, out, and dilated, and that means it's cranial nerve 3. So this is a left medial midbrain lesion. Anytime you see hemiplegia and a cranial nerve 3 palsy, you're dealing with Weber syndrome. That's always in the midbrain, and it's a stroke of branches of the PCA. So let's do another case. This person is unable to do finger to nose testing with his left hand. There's loss of pain and temperature on the left face. There's a left eyelid droop with a small pupil on that side. There's loss of pain and temperature in the right arm and leg. He has a hoarse voice, loss of gag reflex on the left side of the throat, and the palate is raised on the right side. So what I've done here is cross out each of those symptoms and write over it what it means. So the left hand finger to nose testing is a test of your cerebellar system. So if you can't touch your nose and then touch a physician's finger and go back and forth, that means you have ataxia on that side of the body. So that's left ataxia. Loss of pain and temperature to the left face is an issue with cranial nerve 5. The left eyelid droop and the small pupil is a Horner syndrome on the left side. Because the eye's involved, it might trick you and you might think this is an ocular motor problem in the midbrain, but it's actually a Horner syndrome. Loss of pain and temperature sensation in the right arm and leg means the left spinothalamic tract is involved. The hoarse voice is cranial nerve 10, the gag is cranial nerve 9, and the palate raised on the right side is also cranial nerve 10. So putting it all together, the left ataxia means involvement of the spinocerebellar tract. The left face loss of pain and temperature means involvement of the sensory function to the face. Remember, don't use cranial nerve 5 to localize problems to the pons. Instead, use it as evidence of sensory dysfunction, which is one of those S tracts in the rule of fours. The left Horner syndrome means the sympathetic tract is involved. That's another S. And the right pain and temperature means the left spinothalamic tract is involved. That's another S. So all of these are S tracts, so these all localize the problem to the lateral portion of the brainstem. Then we have involvement of cranial nerves 9 and 10 with the problems with speaking and the gag and the palate, so this all localizes to the medulla. So this is a left lateral medullary syndrome, and that's a Wallenberg syndrome, and that's caused by a left pica stroke. So for the last case, we've got right deafness and tinnitus, loss of right finger to nose testing, right facial numbness, no corneal reflex, and facial spasms on the right side. Once again, I've crossed out the symptoms and wrote what they mean on the right side of the screen. The right deafness and tinnitus means we've got involvement of the right-sided cranial nerve 8. The loss of right-sided finger to nose testing means we've got the spinocerebellar tract involved, and that's an S tract, so we know it's a lateral lesion. The facial numbness means we've lost sensory to the face on the right side. Remember, don't use cranial nerve 5 to localize a lesion to the pons. Use it as evidence of sensory loss, and that's one of those S tracts, which means you've got a lateral problem. No corneal reflex means you've lost right-sided cranial nerve 5, and the facial spasms mean you've lost right-sided cranial nerve 7. So putting this all together, this is a right lateral pontine syndrome, and that's what happens when you have a cerebellar pontine angle syndrome, and these are often caused by tumors like schwannomas. So just to summarize how to use the rule of fours, first look for involvement of cranial nerves 3, 4, 6, or 12 to indicate a medial syndrome. Those cranial nerves all divide evenly into number 12, and that makes it very easy to remember which ones are midline. All the other cranial nerves are lateral. And then look for involvement of any of these S tracts to indicate a lateral problem, and any of these M tracts to indicate a medial problem. Now, not all brainstem syndromes are caused by strokes, some are caused by tumors, but if you do see one caused by a stroke, this slide can help you remember the blood supply. It shows the major arteries that supply the medial and lateral portions of the midbrain, pons, and medulla. And that concludes our module on the brainstem.